And so when I did the basal ganglia examination on her on day 1, it was abnormal. And I'm like, great, when we fix that, your seizures will get better. But visit 2, we adjusted her atlas. And visit 3, she comes back, hasn't had a seizure since the adjustment. I go to check her basal ganglia, and it's totally normal from an atlas adjustment. That one, I could not explain how that was possible.
Welcome to the Synapse Podcast. My name is Dr. Chris Slininger. I'm the founder of Synapse Continuing Education, and I'm really excited to have you. The podcast is all about connecting great minds, and we do it by having conversations about the future of healthcare. And today, I'm very excited because we're joined by one of my good friends, somebody who I've known. I actually went to chiropractic college with. I've known for at least 13 years now. And has really pushed the boundaries of innovation in upper cervical care and been quite loud about it. He practices in St. Petersburg, Florida, and he's innovated a lot of the upper cervical technique. He's also added a lot of inventions, a lot of innovations to chiropractic practice tools and chiropractic adjusting tools. He's really just pushed the boundary. So I'm really excited to welcome Dr. Josh Silver. Doc, great to have you on the podcast.
Thanks, man. Thanks for inviting me.
Absolutely. Today, I thought we could really dive a little bit into the relevance of functional neurology, especially in the upper cervical field.
Sure.
And as we start, most of our audience, as we're getting going, is upper cervical chiropractors. That's who we're pushing it out to. So I thought we could actually dive a little deeper today, if it's okay with you. We just wrapped up the upper cervical neurology course, got it launched this summer. Very exciting.
Back in May. That was great.
I'm getting feedback like crazy. I just talked to Jeffrey Van Innes on Facebook, actually, and he was saying, man, it felt like I was in the room. He said the content is so good, but he said it's kind of tricky. And he was just saying it's tricky because it's covering quite a vast subject, but you've been able to boil some of this functional neurology down to a really practical format.
Well, that was the intention, because when I first started learning functional neurology, it was like drinking from a fire hose. It was so overwhelming that you didn't really know where to start on the evaluation. And then you had so many findings, you didn't know where to go from there. And because of that, I kind of get frozen my tracks syndrome. And so that was a whole intention, was how can we boil this down into something that anybody can learn and put together succinctly so that they can actually deliver the goods instead of just having it up in their head floating around.
So when you started going down that functional neurology road, what was your first motivator? Like, why did you pursue it in the first place?
Well, I mean, it was early in chiropractic school. I heard a speaker and he said, "Who wants to be the best chiropractor in the world?" And I really took to that. And so with that being kind of my initial intention, I'm like looking for what's the best stuff in chiropractic today. And when Dr. Carrick came to Life West in my second quarter, more or less this video he showed us was him evaluating somebody's nervous system. It was a woman with Tourette syndrome, and he was able to use his clinical evaluation to understand what was happening in her brain. And he was able to do a simulation to her brain that was very brief, a little bit of warm air in her ear, but somehow was able to rewire her nervous system instantly, and her Tourette's calmed down on spot. And when I saw that, I was floored because it was a whole new realm of healing I didn't even know was possible. And it looked like it was the hardest, but one of the best things in the chiropractic profession. And that was it. I jumped 2 feet in after that second quarter. I signed up for all 20 seminars and I was in it.
Wow.
Yeah.
So I know that you've had a love for upper cervical care from the very beginning.
Right.
But a love for functional neurology that ran right in line with that. So when you looked at the two of them, did you see them as distinct interventions or things that actually wove together?
You know, when I first started studying upper cervical, right, and I first started studying neurology, those were the two things that caught my interest early on. They didn't fit together at all because there was nobody that was really doing the two of them together. And so my ambition at the time was, how do we bring them into together? Because I think that they affect each other. Absolutely. But the functional neurologists weren't really talking about what happened after a good upper cervical adjustment because it wasn't relevant to them. And the upper cervical crowd had no idea of what the neurology guys were talking about with eye roll and vestibular lesions. But over the years, I said, holy cow, one does affect the other. So we can't just ignore one. We have to do them together in a system that melds. And so that's where it really became, hey, maybe we can use the neurology to help that atlas adjustment work better, hold longer, or give them more results. Instead of just saying you're holding, you're good. No, there may be more lesions around the nervous system that are affecting them from getting to their true potential.
So, so you've been in practice for 10 years now.
Just about.
And yeah, it's just about, you're right. You said something really interesting, that you noticed that in the functional neurology world, very few of them understood the impact of an upper cervical alignment. But on the flip side, that the upper cervical people didn't understand the impact of functional neurological intervention.
Correct.
So this will be really interesting. If you could in 2 minutes try to describe, let's say somebody that was doing functional neurology and you were trying to help them understand the impact of the upper cervical subluxation and its correction, how would you describe it to someone who's in functional neurology?
Well, I'd say that you have to stop thinking about the atlas as a tool in functional neurology, right? They'll say, hey, if we push the atlas with an adjustment, we can use it as a stimulation to the nervous system. But in upper cervical care, we don't view it that way. We view that when the atlas is shifted over, it's a lesion generator. It's causing problems for the brain. So when we get it corrected and it stays corrected, that's when we can actually see some of those lesions start to unwind, because we're getting to the root cause of it. And if you were to understand and treat the atlas like that instead of just using it as a tool for vestibular stimulation. There's many ways to get vestibular stimulation. You don't have to do a neck adjustment. If you started treating the atlas that way, be specific, get it to hold, get it to clear up the fog that it's creating in the nervous system, then it ends up leaving it cleans up a lot of the smoke. And then the neuro exam is going to be more specific to the actual lesions that aren't related to their neck. And I think it just makes your life a lot easier. You get to skip a lot of steps that way.
So that's a really good point. Now, I've heard you in one seminar you taught, you were talking about how you went through the science describing why alignment is the key to sustained the restoration of neural pathways, I believe.
That was a big part of it, yeah.
And you're saying that's where a lot of the difference is if you use it as a lever just to activate rather than create a sustained neurological input, that you can actually alter it in potentially wrong ways.
Correct, more or less. I mean, it's the perspective, and functional neurologists tend to be very allopathic in their perspective.
Mm-hmm.
And in allopathy, we have tools that we use to stimulate or inhibit the body. So they're using the atlas adjustment as a tool, but they're ignoring that there's an atlas subluxation behind it.
Got it.
What I'm trying to say is that the atlas subluxation direly affects the nervous system, and you guys aren't even aware that a subluxation exists. So when we come as upper cervical doctors, we remove the subluxation, we clean up a lot of the problems in the nervous system, but because we're not mechanists, we're not looking at all the other pieces around that atlas. We're just assuming they will heal because we're holist. And so that's why we need to kind of have a joint perspective of holism and allopathy, and how do they mix together to give best results.
So if you were to describe to an upper cervical chiropractor the importance of understanding and correcting functional neurological lesions, I mean, you started to touch on it just there, but how would you unpack that a little bit more.
Yeah, and so that was how we started the seminar, was that we know that the atlas will create a head tilt, right? And that will have implications on the body. Now you're bearing more weight on the right side of the neck, and you become more arthritic earlier on that side, and you may be on your right leg heavier and bearing more weight on your knee, and that may become arthritic earlier. And then the atlas subluxation affects the afferents into many different parts of the brain. But my biggest focus is the vestibular nuclei, which is in the brain stem, and that little bundle of nerves or neurons basically helps define our posture, our balance, our eye movement, our awareness of where we are in space, and our autonomic system. And so I believe that when we correct the subluxation, we restore normal proprioception into that vestibular nucleus, it starts to rewire. We see our patients' postures change. We see them getting better. But that subluxation is 1/3 of the input into that vestibular nuclei. I believe that the vestibular inputs from our inner ears are a big part of that pie. What we see visually coming in is the other third of that pie. And then there's other little cues into that vestibular nucleus, like what our feet feel in the earth. But really, it's the eyes, the neck, and the ears. And I think if all we're doing is the neck, we're really only eating 1/3 of the pie and not giving them the full picture. And so the functional neurologists are going to really focus on vestibular rehab. They're really going to focus on ocular motor rehab because they're really concerned about that vestibular nucleus. But when it comes to the neck, I think they're pretty weak, and that's where we may have a leg up on them. But really, the best scenario is all of it together at once.
Okay. That makes a lot of sense. I mean, I've heard you describe it, but it's always nice to hear it from other angles. So sometimes we have to break down terms to really understand what we're talking about. You've been dealing with functional neurological lesions this whole time. Obviously, you're doing it a whole lot more now. It's a heavy part of your practice, but you're not neglecting upper cervical care. Upper cervical care is still the gateway to activate the nervous system. But just to break this down, obviously functional neurologists would understand this one, but how would you just describe what a functional neurological lesion is quickly? Because I know you have an hour dedicated to describing this, but what is it?
Sure. So a functional neurologic lesion, as I understand them, is basically a neuron that's begun to degenerate, whether it's through trauma or transneural degeneration, just not getting used or stimulated. That neuron starts to wind down. And as that neuron starts to wind down, he ends up becoming more excitable because he has a higher resting membrane potential than the other neurons, or what he's supposed to. So a little bit of stimulation to that neuron feels like a lot of stimulation. He fires off way too much. And that creates a abnormal sensory input into the brain. And so we can have these lesions, these sick neurons in the proprioceptive system. We can have them in the vestibular area. We can have them in the ocular motor system. We could have them in the brainstem. I just describe it as a sick neuron that's more excitable, but quick to fatigue, quick to fail.
Okay. So if a neuron is excitable, in what scenario does it not fix itself and get healthy again? Like what is actually inhibiting it from just getting back on track and behaving right?
That's a good question. And I think that simple injuries create simple lesions that tend to correct themselves. And I think that's probably 80% of our life, But when we have a complex injury, then the body needs to make a complex compensation scenario to deal with it. And then we can get stuck into those complex compensation scenarios. And those are a little bit trickier for us to unwind. If you're really lucky in your gym routine, you might hit it. If you exercise a lot, you might unwind it. But it requires very specific types of stimulation to unwind those more complex type pathways. And that's where we have to start coming in as providers.
So when people get under upper cervical care and they're getting their atlas aligned, they're starting to stabilize, do you see a lot of the functional neurological lesions? Do you see a chunk of them resolve themselves?
And it depends, because my practice right now, I don't have an X-ray machine, so I'm not doing really good pre-post adjustments on every patient. Sometimes I'll start with neuro, and then I'll send them out for films, and then they'll come back with that a week or two later. But when I first started really mixing these two, I did have an X-ray machine, and visit one was, let's just find 3 lesions but not fix them. We'll do your atlas first, then we'll check those lesions. And yeah, I was getting, obviously cervical things were disappearing from the adjustment, but what really shocked me was I had a seizure case that came in, and she would tell me she feels this immense pressure building up here, and then she has a little seizure, and that happens 10 times a day. And so first of all, I was like, okay, great, upper cervical case, and probably a basal ganglia case. Basal ganglia is a start-stop part of your nervous system. And so when I did the basal ganglia examination on her on day 1, it was abnormal. And I'm like, great, when we fix that, your seizures will get better. But visit 2, we adjusted her atlas, and visit 3, she comes back, hasn't had a seizure since the adjustment. I go to check her basal ganglia, and it's totally normal from an atlas adjustment. That one, I could not explain how that was possible. So yes, very often the atlas will correct them.
See, I've really liked that approach that you've taken, which is you're identifying that there are definitely weak pathways, weak nerves, sick nerves, basically negative neuroplastic changes. And you're waiting to see if you clear up the afferent and efferent input through the brainstem, through the upper cervical correction. You're actually seeing what resolves and what needs help, and you're distinguishing it instead of just diving in and doing everything at once.
It's been a curiosity thing for me.
Yeah.
You know, I want to see what this atlas is doing for them out of my own curiosity to fully understand the magnitude of what that adjustment means to people.
Yeah.
But whether it corrects that lesion or not, if I can correct that lesion other ways, and in the best interest of the patient, they should have no lesions or subluxations. So I'll go back and forth. Sometimes I'll just fix it because I want them to progress more rapidly in care.
Yeah.
Sometimes, I'll sit back and really observe how amazing this adjustment is.
It's cool. I mean, I think through the years, and even just me watching this process evolve, I think you've definitely landed in a place where you have a very clear system, and it's a patient one. It's saying, look, the body is capable of healing a lot, but occasionally we need help along the way. You know, it's the same like upper cervical care, upper cervical chiropractors. I've heard a ton of them say, all you need is the atlas adjustment. I'm like, yeah, but if you eat Burger King all the time, you're going to be pretty sick. Like, let's think about the rationale of what we're saying. Maybe everything that's coming directly from the upper cervical misalignment might start resolving, but it doesn't mean there's not behaviors, injuries, or compensations that may not need to be directly addressed to get well again.
And if we do address those, then it may help them hold better, which is our whole mission in the first place.
Yeah.
You know? And so in my early days of practice, it was adjust them and sit back and keep an eye on it and fix it if it goes out again. But these days, it's no, let's get ahead of it. Let's fix some things today to make sure that it doesn't slip out of alignment again. And that has just made it so my care plans went from, this to this to this to just shooting straight up.
Yeah.
Because they need less adjustments.
Well, that makes a big difference. And that was your emphasis with the upper cervical neurology course. It wasn't to teach, especially upper cervical doctors, everything about functional neurology. It was to actually help people take a few steps, use a few interventions, and accomplish the primary goal of upper cervical care itself, the holding part.
Right. And I already told you the 3 pieces of the pie, the ears, the eyes, and the neck. So that's all we focused on there, because that's really the most important thing for getting that thing to hold and then have its full, complete recovery.
Yeah.
So no, do Carrick Institute if you really want to know neuro. Do PDTR, do AK, learn about the whole body. But for upper cervical doctors, I was able to condense everything into 16 hours.
Yeah. It was cool. I
Yeah.
mean, it was fascinating. I've seen results. Actually, you're getting a patient I'm sending you, but there are some cases that have a higher level of complexity where even just some of the basics you were showing, I'm like, it's a little out of my wheelhouse. So there's a time and a place for upstream referrals for functional neurology for the more complex ones from what I'm seeing. But I also had a seizure case. I think we did 2 interventions on the eyes and his seizures shut off.
That's amazing.
His atlas stabilized. He was doing great.
It's amazing.
So yeah, I love what you're bringing to the field, and really what we're trying to do with Synapse is help highlight some of these things. This is what I love about it. I'm so glad you were able and willing to do the upper cervical neurology course, but that we're able to produce it, because one of the things that we've been talking about with Synapse, behind the scenes, is it's one thing to just go to a conference and hear some interesting things someone else is doing. It's another thing to actually be able to dive in, take the time, and repeat the lessons until you start to get some mastery in it. So now you get inspired, but you can learn to do it yourself. And that's where advancement comes from. I saw this gap in seminars. Like, usually we have a bunch of keynote speakers, or 1 maybe 2 hour speakers, and you sit there, and by the time you go home, like by the time the plane lands from the conference, 80% of what I learned is out the door. I don't know how to integrate it,
Or it's not clinically relevant.
Yeah. It might be in that person's practice. But if we can start taking information like this, practical functional neurology, narrowed down to accomplish specific goals, the tools necessary to do that, it takes the baseline of our providers and raises the whole field. Even if it's 1 notch up, that's 1 notch up. It's 1 notch higher than we were before, and the outcomes we're going to get are better and better and better.
And I know it. My outcomes went through the roof when I started really using the systems that I teach now.
Yeah.
And because of that, I was able to help more people.
Mm-hmm.
They would hold better. I'd say, I'll see you in 2 months instead of 1, because I know you'll be fine. And I'm able to get more people in the door that way. And so that's the great thing about you getting this out there, is now we can help patients all over the world like this get better outcomes, and that doctor get more people in the door.
So one of the important things that we need to consider when integrating anything into our practice is the amount of time it's going to require to pull it off, to do it with the patient, as well as its value to the patient that can be compensated so that we can maintain profitable practices. That's so important.
Right.
I've heard a lot of things where I've been like, wow, that's so interesting. But if I did it, or unless I knew how to do it right, if I tried to do that, I would actually tank my revenue for the practice. And so it's really important that we talk about these things from a practical standpoint, because 1, we should be doing things that are valuable for people because they work. That's just high integrity, right? But the other side of it is we need to make sure we're sustainable so we can help more and more people over time.
Right.
So on that, when you talk about integrating functional neurology into an upper cervical practice, do you find that people see this as valuable?
Instantly, people are saying he's not like any other doctor I've been to. And because of that, I've got so much value built into these. But one of my core values is that healthcare should be affordable to the people. And that's something I strongly believe. And so we can't do hour-long appointments, because then our care plans have to be $300, $400 a visit, which isn't sustainable for the patient. What I was able to do with upper cervical neurology is make the 5-step process. And it was very simple. Where's the problem? What's the problem? How do we fix it? And then we fix it. Those were the 4 main keys to it. You can do that whole thing in 3 minutes and fix 1 lesion, full evaluation and full correction, 3 minutes, done. And by having it so succinct and so quick, and maybe even a little bit faster when you're good, now we don't have to make our visits so long to be providing this What I'm doing is I have a little bit longer appointment times than I used to have, but I'm charging a lot more than I used to. But I'm not charging so much that people are overwhelmed by the price of it that they say, okay, that's reasonable. I can come, I can do that. And it's been working great for me.
Yeah, and you used to do when you were in California. I think you were doing those half hour, hour long appointments, right?
Yeah, yeah, and we were charging, $3.25 an hour. But that's how long it took to do that traditional model of functional neurology, because every visit was a full exam. You had to look at 98 things, you had to postulate 400, and you had to consider 1,000 different treatments for it. But in my system, it's so much more succinct than that. 3 minutes is all we need. And so now I'll do one, maybe two per session with patients as an add-on. Okay, we checked your atlas. Your atlas was good today. Let's spend 3 minutes fixing something today to make sure that you hold a little bit better and you get more value, more recovery than if we did nothing at all.
So the speed of their progress is increasing, right? From your perspective, do you see that your outcomes are dipping because you're not spending a full hour, or are you actually seeing that they're moving forward quickly, even though it's shortened time frames and in shortened treatments?
Well, no, much better outcomes, because in my system, there's really a definitive endpoint to when the treatment is done.
Mm-hmm.
Whereas in traditional neurology or traditional functional neurology, it's not totally clear when that neuron has reached plasticity. So you have to keep pushing that rehab longer and longer to try and hit that. But with our system of the stimulations, we can get it just like that. So I'm getting better outcomes than ever in faster time than ever. And usually 8 visits, patients are feeling great. And I say, you're on maintenance and I'll see you later. Tell a friend, bring them in and keep me busy.
And with that maintenance, after that 8 visits, are you also seeing that their stability is increasing?
Yeah, absolutely. And that's one of my favorite things about really doing upper cervical with the neurology, because if I only did one, and I've been in practice situations where I was only doing neuro, I was only doing upper cervical, I often felt that I'd say, I'll see you in a month. And the patient would come back and they're like, so glad I had my appointment today. I really started feeling icky a week ago. But now that they're holding for an entire year and we're just supporting that adjustment along the way, no, every month they're like, I feel great, doc. Nothing to fix, nothing to report, nothing to report. And that is way better for them. Even if they have no symptoms in our system, we can still find something to correct it and do it and get them forward.
That's awesome.
It's great, yeah.
But you didn't keep it to yourself, which is what I love the most, is you're making sure that this is accessible and learnable. So the course is on synapsece.com.
Yep.
And that course, it's 16 hours. It was a full weekend, but it covers everything from top to bottom, the principles behind it, understanding neuroplasticity, and then the practical tools of how to actually assess and correct these functional neurological lesions through these systems that are relevant to upper cervical doctors, right?
That's it. I mean, when you get through the course, you'll know how to do what I spend 95% of my day doing.
Yeah.
Yeah.
That's awesome. Well, yeah. So if you're interested in checking out upper cervical neurology, go to synapsece.com/courses. And on that page, you're going to be able to see upper cervical neurology. It is it's a worthwhile investment. We've had a bunch of people go through it live. We've had a bunch go online, and we're getting feedback from the people going through it online. I think you had one person stay up all night. They messaged you afterwards, right?
Yeah. Pulled an all-nighter to finish it.
That's awesome. That's unusual. But the nice thing is they can repeat. Like we're selling access to courses, not a one-time access, but something that you own, you integrate, and you move forward.
And with the amount of content I put into those 16 hours, you need to be able to pause, rewatch, and rewind.
That's right.
Yeah.
That's right. So yours isn't going to be alone. You have other people up the pipeline, and we have more coming soon. I'm really excited about that. But yeah, synapsece.com/courses. We're going to continue to be producing courses from experts that do these very outside the box things, but every single course that we're going to be doing on Synapse or through Synapse is going to be a course that's practically applicable. We are going to be talking, make sure all the content talks about how to integrate it in an efficient way, make sure it's profitably integrated into your practice, how to communicate it to the patient, and how to actually market it so people know that you are doing that skill. That's a big prerequisite for anything through Synapse, because that's the only way we grow as a profession. We become better as providers, and the patients get better outcomes that they've been desiring. So we are going to make sure we meet that mark every single time. But
Thank you so much for putting this together, and I'm honored to be the first speaker with Synapse.
Well, it's an honor to have you.
Yeah.
No, it's really exciting. Thank you so much for your time.
I appreciate it.